Okay, guys, so the topic that was given to me today is on meningitis and also encephalitis. So my name is Dr. Chi. I'm from the Department of Medicine, and I'm a general physician with special interest in neurology. So I'll bring you through this topic of basically central nervous system infection, focusing on meningitis and also encephalitis. All right, so you guys can see my pointer here moving here and there, right? All right, so this is going to be the outline of my presentation. I'm going to introduce to you what is the definition of meningitis and also encephalitis. Following that, I'm going to talk about how do they usually present to us. What are the things that are important of physical examination? How do we investigate to it? And also, finally, how do we treat them? So, before we start, it is prudent to understand the definition of the terms that we are going to use in our subsequent slides. So, meningitis and also encephalitis. So, if you recall the anatomy of the brain meninges that you have learned during year one, I remember it using the mnemonic DAP, so like the political party. So, on the outermost layer, it is the dura mater. D followed by arachnoid matter, and also closest to the brain parenchyma, it is the pia matter. All right. So basically, in simple terms, meningitis refers to inflammation of the meninges, whereas encephalitis denotes inflammation of the brain parenchyma. Okay, so in simpler terms, okay, if it is only at the covering of the brain, it is known as meningitis. If it extends, how do I say, to involve also the brain parenchyma, it is known as encephalitis. But really, in clinical practice, it is not so straightforward. Usually, we don't say, okay, this patient has pure meningitis, this patient has pure encephalitis. Most of the time, we use the term meningoencephalitis because any inflammation, they tend to involve adjacent structures. So the meninges and also the brain parenchyma, they are very close to each other. So meningoencephalitis. Rome encephalitis basically refers to inflammation or infection of the posterior fossa involving the brainstem and also the cerebellum. All right. Whereas encephalopathy, it is just a clinical syndrome whereby the patient has reduced consciousness and also impaired brain function. All right, so that is the meaning of encephalopathy. All right. So if we look at how do I say this slide, okay, this is showing you the epidemiology of bacterial meningitis in the USA. You can see that how do I say the incidence of meningitis is how do I say reducing over the years. I think this can also be replicated in how do I say in our setting. Okay, the reason is actually due to the introduction of vaccine. So nowadays we have pneumococcal vaccine, meningococcal vaccine. All right, so that reduces the incidence of meningitis considerably. All right, so I don't think it is part of our national immunization schedule yet, but for those who have been to Umrah, you'll notice that before you go, you need to take certain vaccines. So these are the few vaccines that has been proven to be able to reduce the incidence of bacterial meningitis. All right. So, okay, Muhammad Muslim, do you want to ask any question? All right. So, how do I mute him? Okay, so for your level, you need to know what are the how do I say common pathogens that are associated with bacterial meningitis. This will come out in the exam. Okay, on the slide, I've shown you a few of the how do I say common organisms that we usually face in clinical practice. The most common one is still strep pneumonia and also Neisseria meningitis in our clinical practice. All right. So if somebody asks you or your tutor asks you, what are the common pathogens, how do I say that are implicated in bacterial meningitis, the way that you answer them is, sir, it is actually dependent on what age group that we are talking about, because pathogens in the neonatal group, in the children group, and also adult group, they are different. All right. So, but in this slide, I'm just showing you the common organisms that we usually have strep pneumonia, Neisseria meningitis, and also Listeria monocytogenes. All right. So this is a very good table showing you how different it is. How do I say the common organisms in meningitis in differing age groups. So, for example, in the neonatal group, you can see that most of the how do I say pathogen implicated 58% as compared to the rest is actually Streptococcus agalactiae. All right, so this is a group B Streptococcus. All right. So if you grow a bit older, this is the pediatric age group, all right? Most of the organism is actually Neisseria meningitis, all right? But if you grow older to the adult, how do I say, age group, you can see that there is a change in the, how do I say, common pathogen implicated, whereby the most common cause of bacterial meningitis becomes streptococcal pneumonia. All right. So depending on which posting that you are doing subsequently, be it pediatric or adult medicine with me or the geriatric medicine, involving the elderly population. So the most common implicated pathogen changes with your age group. All right. So other than how do I say bacterial, how do I say pathogens, viruses can also cause meningitis or also encephalitis. So being shown on this table is actually some of the common viral causes of encephalitis. So top on the list is actually your herpes simplex virus 1 and 2, followed by your varicella zoster virus, your chickenpox virus. All right. So the other viruses like the cytomegalovirus, Epstein-Barr virus, they are much, how do I say, more uncommon. All right. So bear in mind things like measles and mumps, rubella. They can also cause encephalitis, but of course they are not so common nowadays because we received MMR vaccines when we were small. All right. So rabies. So I think if you follow our DG Noisham today, you'll see that there is a few scattered outbreak in Sarawak where they have rabies. All right, so rabies can cause encephalitis. Dengue, which is very common in our how do I say community, can actually cause encephalitis. This is under arboviruses. If you know, dengue virus is actually classified as arboviruses, and also Nipah viruses. Okay, that was discovered in Malaysia. All right. So just to show you that how do I say there is also a difference between the types of viral pathogen how do I say in different age groups. So if you look at the patients who have been diagnosed with viral meningitis, okay, comparing those patients less than 16 years old versus how do I say more than 16 years old, you'll find that younger patients they tend to have enteroviruses, but as you grow older, herpes simplex viruses type 1 and type 2 becomes the predominate, how do I say, organism. All right. Also, Epstein-Barr virus, as you grow older, okay, you do not see them usually in patients less than 16 years old. All right. So, depending on where you work, your suspicion on the types of pathogen that your patient might have may differ. All right. So, what about the symptoms? All right. So, this, how do I say, slide basically wanted to show you what are the common symptoms that the patient present. All right. So, as you can see, dominating the table being shown, headache is, how do I say, occurring almost 100%. How do I say, in patients with, how do I say, meningitis or encephalitis. All right. Nausea and vomiting are also common symptoms like stiffness, photophobia, and also fever. Okay, so you can also have rashes, especially with enterovirus, how do I say, CNS infection. So for your level, you just remember you need to know the common presenting features of patients with meningitis and encephalitis. All right. So these are the common ones: headache, neck stiffness, nausea, vomiting, high grade fever, photophobia, and occasionally rash. All right. So how do I say meningitis and also encephalitis happen? All right. So it can happen through hematogenous spread, or it can happen through direct spread from the nasopharynx to the subarachnoid space, or from the ear canal to the brain. All right. So and some of these viruses that we have discussed just now actually travels how to say, in a retrograde fashion along the neurons. All right. So this is a very good, how do I say, to show you. So for example, bacteria will colonize your nasopharynx. Okay, so when there is a break in the mucosa, the bacteria or the viruses actually travels through the mucosa into your bloodstream. All right. So when the how do I say, when the bacteria is in the bloodstream, it will get seeded in the CNS system. It will get seeded in the brain. All right. So when the bacteria is in the meninges. All right, so these are all the meninges. All right, so this is the vessel, So the bacteria travels from the vessel into the meninges. It causes a lot of inflammatory response, and then you can get all these pus over here or all these inflammatory components. Lah. So when you have a lot of inflammatory response, think about the hallmark of inflammation. You have redness, you have swelling. Okay, so it increases the pressure in the brain, and patients can have symptoms. All right, so the same thing can happen, from the ear canal. Okay, so that is how bacteria or viruses actually invades our central nervous system. Okay, this is the common scenario. All right. So, knowing when to suspect meningitis or encephalitis is very important. Okay, again, it depends on the age group of patient that we are dealing with. For example, infant is not going to tell you, oh doctor, saya ni sakit kepala, saya ni tengkuk ni rasa keras. No, infant, for example, present only with poor feeding, or okay, or they have pale or mottled skin, they become very hypotonic. All right. So elderly sometimes they only present with altered mental status without any focal neurological deficit. All right. So for example, adult and also children, they can present to you with a classical triad: fever, neck stiffness, altered consciousness, headache. All right. So sometimes you don't find anything, but rashes, and also headache and fever. Okay. So in more severe stages, sometimes you can have seizure. Okay, but usually when you have seizure, it basically suggests that there is a space occupying lesion in the brain, for example, abscesses, empyema, or bleeding in the brain. Okay, that causes raised intracranial pressure followed by seizure. All right. So the clinical features of bacterial meningitis in adults that you need to know include headache, fever, neck stiffness, and also altered consciousness. So if your patient fulfills four of these cardinal symptoms, 95% of your patient, it is very likely, almost 95% that your patient is having meningitis or encephalitis of the central nervous system. So look hard for all these clinical signs. All right. So what do we usually ask in the history? So for example, how do I say, a recent rash may suggest varicella zoster infection. All right. So if the child or if the patient have parotitis, okay, inflammation of the parotid gland or testicular pain, it could suggest mumps. All right. So if they are complaining of some strange smell, it could be herpes simplex virus. All right. Travel history becomes very important. Okay, because sometimes you can have some exotic CNS infection. Okay, occupational and also recreational activities, and also high risk behavior. All right. So nowadays we have COVID-19. Okay, so COVID-19 has also been proven to cause meningitis and also encephalitis, but I didn't include it in this slide. All right. So a few of the important things to be looking out for in examination, okay, include focal seizure, focal neurological sign. Okay, sometimes you can have movement disorders like tremor or chorea, and that usually denotes basal ganglia involvement. Okay, look for lower cranial neuropathies, meaning the lower cranial nerve involvement. The lower cranial nerve involvements, how do I say, I'm referring to cranial nerve 9, 10, 11, and 12. All right. So sometimes due to viral infection, you can have hepatosplenomegaly, and also to look for signs of immunocompromise, because if you're immunocompromised, you're dealing with a wider array of organism. All right. So for example, if I have a immunocompetent patient, I wouldn't be thinking about those how do I say, organism that will only happen in immunocompromised hosts like HIV. So contohnya cytomegalovirus. Okay, usually it doesn't happen in immunocompromised immunocompetent host. But if you have a patient with HIV comes in with meningitis and encephalitis, you might want to think about this rarer organism. Okay, so what are the signs that you look for? You look for injection sites, oral candidiasis to suggest that they're immuno compromised. All right. So in your textbook, you're probably how do I say familiar with the Brudzinski and also Koenig sign. They are not very sensitive. Okay, you cannot say that because these signs are absent, the patient doesn't have meningitis or encephalitis. Brudzinski means that you flex the head. Okay, you'll find that the hip and also the knee is also flexed. All right. So Koenig sign means that how do I say you flex the hip, you try to extend the knee. Okay, the patient will refuse due to pain. All right. So these are the two classical or rather traditional signs that we have learned during medical school. Okay, sometimes infection of the brain, okay, is only confined to the posterior fossa, and that is what we call Rome encephalitis. All right, so if it is at the posterior fossa, you only have involvement of the posterior fossa structures like lower cranial nerve involvement. Okay, patient might have brainstem dysfunction. All right, and when you do imaging, all these changes are around the brainstem and also the basal meninges. All right. Okay, so just to recap, what are the clinical presentation of patients with bacterial meningitis? Okay, other than headache, nausea, vomiting, neck stiffness, rashes, fever, comatose or coma, and also focal neurological deficit can happen. All right, but remember that if you have a triad of fever, neck stiffness, and also of the mental status, sometimes it will only pick up about close to 50% of the patient. Okay, bear in mind that I told you the clinical presentation sometimes present on the age group and also the immune status of the patient. All right, so you can see what is the recommendation given by the guideline. It says that in adults with bacterial meningitis, sometimes classic clinical characteristics may be absent, and therefore bacterial meningitis should not be ruled out solely on the absence of classic symptoms. You need to have a very high the index of suspicion. All right. So here it says that the Koenig and also the Brudzinski signs has very low sensitivity and also negative predictive value. So do not say that the patient does not have any meningitis if the Koenig and also the Brudzinski signs are negative. All right. So what are the investigation that we usually do? All right. So of course we send off the usual blood investigation. We can send off the full blood count. Okay, to look at the white cell count in the blood. If the white cell count is very highly elevated, then it suggests an ongoing inflammatory response or infection process. Patients can also have an organ involvement, for example, renal impairment, liver function derangement. That's why we usually send them off. Okay, blood cultures is to help us to diagnose any bacteremia. Okay, HIV serology because you need to make sure that the patient is not immunocompromised. Chest X-ray is also very important because, for example, if you find a lot of cavitation or consolidation in the lung, okay, in a patients with CNS presentation, you might want to think about TB, pulmonary TB, together with CNS TB. Okay, so after all this basic investigation, taking blood and ordering for chest X-ray, then we send the patient for more advanced imaging like doing the CT brain, MRI brain, and also lumbar puncture. Okay, so lumbar puncture is a very crucial investigation when treating patients with how do I say meningitis or encephalitis because lumbar puncture that is properly done will tell us is there infection or inflammation okay, in the CSF. Is it more likely to be a viral cause or bacterial cause? Okay, and also the CSF culture can guide us in the type of antibiotic that we are gonna give. So usually we send off all these things when we do a lumbar puncture. Things like the CSF biochemistry that will tell us what is the glucose and also the protein in the CSF, gram stain to see whether or not there is any stainable bacteria culture, acid fast bacilli smear, and also the TB culture. Okay, Indian ink and also cryptococcal antigen. It is to diagnose how do I say cryptococcal meningitis. Okay, we send off the CSF for viral PCR for the common viral pathogens that I've talked to you just now. All right. So HSV PCR has a sensitivity and also specificity of more than 95%. All right. So the most common viral pathogen in our setting to cause encephalitis is the herpes simplex virus, and the PCR is readily available even in HUSM. All right. So like I mentioned before, you need to find out what is the immune status of your patient. For example, CMV and also EBV, they are more common in immunocompromised patient. That's why usually we find out whether or not the patient is taking any steroid, long-term steroid. Are they, how do I say, transplant recipients? Have they done any chemo before this? Okay. Are they HIV positive? So all these are important pieces of history to find out. All right. So sometimes the doctors, okay, are a bit cautious in doing lumbar puncture. All right. So because if there is a space occupying lesion in the brain, and if you do lumbar puncture suddenly, it can cause cerebral herniation. All right. So you need to think twice when you have red flags, okay, that could suggest a very elevated intracranial pressure or a space occupying lesion in the brain. So, what are the clues? The clues include focal neurological sign. If you have a patient coming in confused and you find that one side of the body is not moving, the patient comes in with seizure, okay, or the patient comes in, you examine the fundus, you find papilloedema, okay, papilloedema suggests raised intracranial pressure, or your patient is in very deep coma. Okay. Some other clues include immunocompromised status, for example, HIV patient. We are usually very careful before we do a lumbar puncture because most of the time they can have space occupying lesion in the brain. All right. So abnormal dorsal eye movement and also patients with coagulation abnormalities, for example, very low platelet or deranged, how do I say, coagulation profile, you might want to think twice before you stuck a needle at the patient's back. All right. So CSF analysis will help to guide us. For example, in this, how do I say, slide, you can see that in different pathogen, okay, the CSF findings will be different. Okay. So for example, bacterial meningitis, they usually have, how do I say, higher opening pressure than viral meningitis. They have more cells, usually neutrophils, polymorphonuclear cells, as compared to viral meningitis. Viral meningitis usually gives you lymphocytes. All right. Okay. TB, for example, give you how do I say predominantly lymphocytic how do I say CSF as well. All right. So we also look at the how do I say glucose and also protein in viral meningitis or bacterial meningitis and also meningitis, the protein is usually elevated. All right. So in with regards to the glucose, for example, TB meningitis has very reduced CSF glucose. All right. So like what I said, the CSF sometimes will help you to guide you, okay, to tell you what is the most likely organism, okay. You probably don't need to, how do I say, memorize the whole table, but you need to know the distinguishing features of each and every pathogen, for example, all right. Okay, so this is another very good, how do I say, table to show you some of the key differences between different etiological agent of, how do I say, meningitis. All right, so for example, opening pressure is usually very high in fungal, and in viral meningitis, it is usually normal. All right, the cells, okay, is usually very high in bacterial meningitis. Okay, the differential count, okay, for white cell count, usually in bacterial meningitis, it is high in neutrophils. In tuberculous meningitis and also in viral meningitis, it is usually lymphocytic in nature. Okay, so we measure the glucose in the CSF. All right, so the ratio of the CSF to plasma glucose is usually very, very low in tuberculous meningitis. With regards to the protein, usually it is very high in bacterial meningitis. In viral meningitis, it is usually normal or slightly elevated. All right. So the normal opening pressure for adults, it is usually less than 20 cm water. All right. So bear in mind that if you have a bloody tap, meaning that when you do a lumbar puncture, the operator is very rough or is a junior doctor, and that results in a traumatic tap, meaning blood coming out. Sometimes blood, if it mixed with the CSF, it can falsely elevate the white cell count and also protein. Okay, so it depends on the skill lah. But if there is blood, also sometimes you can correct it by applying some formula lah. But you probably don't need to know in detail. All right. So, like I mentioned, okay, the CSF constituents or the components of the CSF will help you differentiate whether or not it is viral, bacterial, fungal, or tuberculous. All right. But if you are very into this field, or next time when you want to further your studies in neurology, you'll find that even within those with viral meningitis, okay, different viral agent will give you different how do I say CSF findings as well. So for example, okay, for the cell count, they somehow find that patients with enterovirus meningitis, they tend to have a lower leukocyte count as compared to those with the herpes simplex virus or the varicella zoster virus. Okay, that applies to the protein as well. So protein is lower in those with enterovirus viruses, right? Okay. So I've actually talked to you regarding what do we do with the CSF. All right. So we stain the CSF because if you apply the stain, you see gram positive, gram negative, you might diagnose bacterial meningitis straight away. All right. We send off the culture and sensitivity, hoping that they will grow something. All right. And bear in mind that if you treat the patient with systemic antibiotics before obtaining the CSF, it will also decrease the yield of gram stain and also culture. That is why, preferably, before you give any antibiotic to all these patients, take whatever blood, whatever CSF sample that you need, then only administer the antibiotics. All right. All these culture gram stain, they are only applicable to bacterial pathogen. If you are thinking along the line of viruses, viruses cannot be cultured, okay, conventionally. So you probably need to use a PCR technique to identify viruses. All right. So I'm gonna skip this. Okay, if I just how do I say confuses you. All right. So sometimes the timing of doing a lumbar puncture is also very important. Looking at this slide, okay, on the x-axis it is the duration of the day. Okay, on the y-axis it is actually the amount of lymphocyte. You can see if you take the CSF too early, you do a lumbar puncture too early, for example, on day 0, on day 1, you find that the lymphocyte counts are usually low. But as the disease progresses, usually you can find that the lymphocyte actually increases. So sometimes it depends on the how do I say timing of you doing the investigation as well. Okay. Okay, so different method of CSF examination, how do I say, gives different yield. For example, gram stain is only 50% to 90%, how do I say, positivity. All right. So sometimes it also depends on the type of bacteria. Some bacteria are more easily stained than others. The same applies to culture. Some bacteria, they are easily cultured than the other. For gram stain, it is easiest to gram stain streptococcal pneumonia, followed by Neisseria meningitis, followed by Haemophilus influenza type B. For culture, it is much easier to grow Haemophilus influenza, followed by streptococcal pneumonia, and also Neisseria meningitis. All right. Okay, so just now I mentioned to you that for bacteria, we can do gram stain and also culture. For viruses, we need PCR. But PCR has a disadvantage. PCR can only tell you what kind of viruses that you are how do I say, dealing with, but it cannot tell you what is this virus is susceptible to what kind of antiviral agent. It can only tell you what virus it is, as compared to culture and sensitivity for bacteria. Other than on top of growing the organism, it can tell you, okay, this streptococcal pneumonia is sensitive to penicillin and resistant to what not. All right. So other than the usual tests that I've mentioned to you in more advanced lab, sometimes we send the CSF for lactate and also procalcitonin. So these are more advanced markers that can be helpful to differentiate bacterial versus viral meningitis. Okay, so the conclusion is that how do I say, if the lactate is high and also the procalcitonin is high, the likelihood that you are dealing with a bacterial meningitis is higher than viral meningitis. All right. Okay, so it is very important to treat bacterial meningitis as early as possible. All right, if you start therapy early within 1 or 2 hours, you can reduce morbidity and also neurological sequelae significantly, and that can translate further down to reduce mortality. So the longer you wait, the higher the mortality and also the higher the chances of the patient having neurological sequelae. Having neurological sequelae means maybe permanent, how do I say, paralysis of the limbs, or speech deficit or memory impairment. Okay, whatever lah. Okay, so time is brain is very important to remember this concept. And authoritative guidelines around the world strongly recommend starting antibiotic as soon as possible in acute bacterial meningitis patient. Okay, they say it should not exceed 1 hour. So if you have a patient coming in through the emergency department that you suspect is having bacterial meningitis, antibiotic should be given within 1 hour. All right. So at any point, if you think that it is going to be delayed for you to complete the investigation, for example, there's a delay in doing like a puncture or doing a CT scan because you need to transfer the patient to a nearby tertiary hospital, give antibiotics immediately, empirically treat it, okay, while waiting for further investigations to be done. All right. So we have finished talking about blood cultures. We have finished talking about CSF examination. Next come neuroimaging. Okay, so neuroimaging is very important because we need to know where is the infection happening inside the brain and how bad is the infection. Okay, can you guys mute your mic? Thank you. So the indications for brain imaging. Kevin is your mic is on. Can somebody mute him?
Ah, what? No.
Kevin, can you mute your mic? Okay, I've just muted. Okay, so there are a few indications that we do brain imaging. So, for example, if you have patients with anything lah, anything that suggests a space occupying lesion in the brain, like I've mentioned to you just now, if you find patients that comes to you with focal neurological deficit, okay, or you find papilloedema, cranial nerve palsy, a new onset seizures, you need to do brain imaging because only through imaging you can detect all the complications that is happening in the brain from the infection. For example, hydrocephalus, infarct, empyema in the brain abscesses, and also venous thrombosis. So without imaging, you cannot know what is happening in the brain. All right. So this is a CT scan, all right? So of a man with HSV and cephalitis. All right, HSV means herpes simplex virus. You can see that this is the CT scan of the brain, and over the left medial temporal lobe. Okay, for you guys who probably don't know, this is the temporal lobe. This is lateral. This is medial. So the medial temporal lobe, there is an area of hypodensity. All right. So the medial temporal lobe is a favorite spot for HSV viruses. Okay, so if you see hypodensity here, the most likely pathogen that you are dealing with is probably herpes simplex virus. All right, so the location of the brain involvement can sometimes give you a clue. Okay. So forgot to mention that these two CT scan is done, how do I say, 4 days apart. Sometimes if you do the CT scan too early, you'll probably see some faint changes, but you're probably not very sure. Okay. If you repeat it much later, for example, in this case, 4 days later, you can see that there is confluent, how do I say, hypodensity over the medial temporal lobe. Okay. So nowadays we have MRI, so even easily available in our hospital. Okay, this is an MRI showing you the exact location in a patient with herpes simplex virus and cephalitis. On the CT scan, you might not see very clearly because on the CT scan it is only black or white. Okay, very crude. Okay, but you if you do an MRI, you can see that it is very well delineated over the medial temporal lobe. All right, so involving the insula of the brain. So this is the common location for how do I say herpes simplex virus to infect. Don't ask me why herpes simplex virus likes to be there. Okay, it is just something that has been observed over years, over decades. Okay, so if I have a patient coming in with headache, confusion, seizure, personality changes with some fever, I do an MRI, I see this kind of picture on the MRI, I'll say, aha, this is most likely herpes simplex virus and cephalitis. Then I'll order for CSF examination. So I'll write in the chart, send off HSV1 and 2 PCR. Okay, because given the history and also the imaging finding, I am highly suspicious of herpes simplex and cephalitis. Okay, so this is just to show you how is it related to clinical practice. All right. So this is another patient with encephalitis also, okay, but this time at a different region of the brain, okay. So just like it was around here again for herpes simplex encephalitis, the medial temporal lobe I mentioned just now. But in this patient, okay, he has lesion in the thalamus. Okay, so you can see both thalami, they are brightly lightened up. Okay, so this is a common, how do I say, spot for Japanese encephalitis. Okay, remember 20 years ago when we had an outbreak of Japanese encephalitis? Maybe you guys weren't born. I remember during that time, how do I say, my mother banned me from going to swimming classes because we are afraid that some other people might transmit the virus to me. So that's the reason until now I still do not know how to swim. So I blame JE virus, okay, that had an outbreak almost 20 years ago. So different viruses, they have different, how do I say, region of the brain that they like. So for example, in some herpes simplex virus, they like to reside in the temporal lobe. For Japanese encephalitis, they like to sit in the thalamus. Okay, so chikungunya, they like it in a different area. Nipah virus different. So it basically tells you, okay, just to convey the message that when an experienced neurologist views at the MRI, we can roughly guess what could be the pathogen implicated. Okay, is it more likely to be bacterial, more likely to be viral? Okay, of course, it is not a standalone investigation. Okay, bear in mind that physical examination history. Okay, routine blood investigation, CSF analysis, followed by MRI. So we take all these things into account to make a sensible diagnosis. All right. So another common organism in our country, Malaysia, it is actually tuberculosis. And tuberculosis can mimic a lot of things. Okay, it can infect the brain and also the spinal cord. Okay, so they can come in with meningitis, they can come in with encephalitis, they can come in with tuberculoma, brain abscess, vasculitis. So macam-macam. This TB is very, very notorious and it is very common in our country, especially in areas where people are poor. Okay, they have a lot of pendatang tanpa izin and a lot of foreign workers. All right. So there are ways to diagnose tuberculosis. So, for example, how do I say, when we do the how do I say when we do the CSF, okay, it is usually lymphocytic predominance. Okay, cell count is not very high as compared to bacterial meningitis that can go up to 5,000, 6,000, 10,000 cells. Usually, it is less than 1,000. The duration of illness is usually more prolonged. Bacterial meningitis usually come in 3 or 4 days, very ill, high grade fever. So if you have somebody who comes in with weeks of symptoms, probably you're dealing with how do I say tuberculosis. All right. So there are a few tests that we usually send them off to diagnose CNS TB. Okay. So, for example, we send off the CSF for acid fast bacilli staining. Okay, we send off the culture for TB and also PCR for TB as well. Okay, so this is the classical appearance of TB meningitis. All right, so this is an MRI. Okay, they put in contrast, and you can see this is basal enhancement. So from anatomy, you learn about the how do I say the circle of Willis at the base of the skull, at the base of the brain. Okay, so this area is actually full with exudates and also all these dirty inflammatory materials due to TB. All right. This is another patient with a tuberculoma here. Okay, so it is a mass, a small mass located at the cerebellum. Okay, you can see some signal changes within the brainstem. This is the pons, right? So showing you another MRI images of somebody with TB, how do I say? You can see cavitation. Okay. So this looks like a ring kan, macam ring untuk Green Lantern kan, betul tak? So this is a cavity. Okay. So this is a tuberculous abscess. Okay. This happened in a patients with HIV and also brain tuberculosis. Okay. So when he was treated with anti-TB, anti-tuberculosis therapy, all these lesions disappear. Okay, so as you can see here, it appears darker as compared to here, right? Okay, so this area that appears darker, actually it is due to edema. Okay, so surrounding this abscess, you have surrounding edema. Okay, so that is the reason why it appears darker. Okay, so how do we manage? Okay, so how do we manage how do I say all these CNS infection? Okay, it is too brief for me to tell you in 15 minutes lah. But the main concept is how do I say number one, you need to reverse or stop the disease process. You need to be able to diagnose and address the complication. Okay, and also at the same time prevent late complications. So these are the principles of management of bacterial, viral, or fungal, or tuberculous meningitis or encephalitis. Okay, so this probably you will not find it very relevant at your stage of your study because you're just year two. But as you progress, how do I say later, you are expected to know what are the common antibiotics that are given to patients with bacterial meningitis. Okay, so I've highlighted here in the adult age group, for example, 18 years old to less than 50 years old, ceftriaxone, okay, is the preferred antibiotic. So ceftriaxone is actually rocephin, right? So the dose that we usually give is actually 2 gram, okay, every 12 hourly. All right. So there are different dosing of the antibiotics that you need to take note. So for example, ceftriaxone, if you give 2 gram once a day, meaning every 24 hours, it doesn't reach high enough level to penetrate the brain. Okay, only when it is given every 12 hourly, meaning twice a day, the antibiotic reaches a good concentration to penetrate the blood-brain barrier to kill off the bacteria in the brain. Okay, so that was for bacterial pathogen. All right. So how about how do I say viral? So how about for our viral pathogen? So for viruses, we usually give acyclovir, which is an antiviral. Okay, it is only effective against two viruses. Okay, so just now I talked to you about different kind of viruses. You have your HSV, V, you have the Epstein-Barr, cytomegaloviruses, adenoviruses, influenza viruses, your COVID-19 is also a virus. All right. So there are only two that can be treated. Okay, as far as we are concerned, they are herpes simplex and also varicella zoster virus, where we can treat them with acyclovir. All right. So for those who have chickenpox before, you'll recall probably popping acyclovir tablets lah. So for brain, herpes simplex or varicella zoster encephalitis, the acyclovir is given in the IV form instead of oral form. All right. So there are also some people who believe giving corticosteroids in bacterial meningitis. Okay. So remember the slide where I show how bacteria travels from the nasopharynx to the meninges. Okay. So when you have bacterial infection, okay, the inflammatory response is very overwhelming. So it produces a lot of exudate. And this inflammatory response sometimes can damage nearby or adjacent structures. So there are people who believe giving dexamethasone, you can reduce, dexamethasone is a form of steroid, can decrease the hearing loss, it can decrease any neurological long-term sequelae and also reduce mortality. Okay, but not everybody is practicing it. So here we do not practice it. All right. So before, I think I'm nearing towards the end of my presentation. Okay, we have talked about bacteria, we have talked about viruses, fungal, okay, tuberculous, okay. There is this new group of meningitis or encephalitis that is not due to infective agent, okay. There's this emerging field of study on autoimmune encephalitis, meaning your body is producing some form of antibody that attacks the brain. Okay, it has nothing to do with infectious organism. Okay, so giving all these antibiotics will not help. Antiviruses, they will not help. Okay, but giving steroid to suppress the immune system of the body will help. Okay, so just like SLE, rheumatoid arthritis, Graves' disease, thyroid, autoimmune thyroid disorder, you can also have autoimmune disorder that targets the brain. All right. So I know you guys have a lot of free time at home, okay, watching Netflix. So later, when you switch on Netflix, look for this movie called Brain on Fire. Okay. So Brain on Fire is a real life story, actually talking about a girl who was diagnosed with NMDAR encephalitis. Okay, it is an autoimmune encephalitis. All right. So NMDA antibody go and attack the brain, causing how do I say neurological dysfunction. Okay, so usually they come in with hallucination, anxiety, delusion. They become very agitated and very aggressive, and in how do I say later stages they can have seizures. All right, and it is strongly associated with some form of malignancy in the younger population. All right. You don't have to remember because I think in the textbook in the Kumo and Clark is probably not included because this is something rather new, I think, for the past 10 years or so. Okay. So this girl in Brain on Fire, very chantik, and you can see the nose is very, how do I say, very tajam, just like Auni. Um, this girl presented with hallucination and also psychiatric manifestation. So she was admitted to the psychiatric hospital in the movie, and everybody say that oh ini orang gila lah. So the psychiatrist made a diagnosis of schizophrenia. Okay, but this girl knew that how do I say she's not crazy. Okay, she knew that something is going on, with her until she finally met a very smart neurologist who after he examined and taken the history came to a conclusion that no, she's not crazy. She has NMDAR encephalitis, and she was treated, and she subsequently became well. Okay, so the most well-known autoimmune encephalitis is the NMDAR receptor, NMDAR encephalitis. But you have many, many other more antibodies towards the brain that how do I say, at your level you probably don't need to know. Okay, but just bear in mind that other than infectious etiology, you can have non-infectious etiology, and one of the very important non-infectious etiology of encephalitis is autoimmune encephalitis. All right. So these are my how do I say, references. Okay. So the ASME guideline is the guideline that guides clinicians how to diagnose and to treat bacterial meningitis. All right. Okay, so I think that's the end of my how do I say, presentation. I'm gonna stop my recording first, and then I can take a few questions. Or if you guys are very shy, you can always just type in, and then I'll respond to you. Okay, any question? Okay, very good question. Ui Chin Lin. Okay. Wei Chinlin sent me a message privately. Okay, so Wei Chinlin actually asked, "Good afternoon, doctor. Can you explain what is opening pressure?" All right. So we have the brain and also the spinal cord, right? So usually lumbar puncture is done with the patient in the fetal position, meaning you lie down, you curl up, and then the doctor insert a needle to your back, okay, and retrieve the cerebral spinal fluid. Okay, the pressure when we insert the needle, okay, is known as the opening pressure. So we attach the needle to a device that measures the opening pressure. Okay, so if the pressure is high, it basically means that the pressure in the brain is high. Remember that your CSF circulates from the brain to the spinal cord in a continuous fashion. Okay, so any high pressure in the brain will be translated to a high opening pressure. So if the opening pressure is very high, it means that the pressure in the brain or the central nervous system is very high, and it actually helps you narrow down the diagnosis. For example, bacterial meningitis and also fungal meningitis typically gives you very high how do I say, opening pressure. Tuberculous meningitis also. Okay, viral meningitis, usually the opening pressure is sort of like normal or just mildly elevated. All right. Okay, I hope that answers your question. Any other questions? You can just post in the chat. Wei Chinlin replied, understood, doctor, but she again replied me privately. She likes to do things private for some reason. Any more questions? Ahmad Zarif, Amir Irfan, Ainin, Arvina, Pretty, Arvina, Pretty. You're very pretty, but do you have any question? Okay, Arvina. Okay, so we have a question, how do I say, from Imelda. Okay, doctor, can we say that the bacteria and virus pass the blood-brain barrier? Yes, how do I say, on a superficial level, you can say yes. Okay, the bacteria or the viruses colonizes our oropharynx or our auditory canal, and spread through direct invasion. Okay, to our central nervous system, passing through the blood-brain barrier. You can. You can say that. I think I don't know whether you guys feel overwhelmed with the presentation, okay? Because this is a last minute presentation. Dr. Sabarisa just PM me like 2 days before, okay? So year two, I think the take home messages are as follow. Number one, meningitis and encephalitis are medical neurological emergency. Okay, you should not miss this kind of diagnosis and you should act upon it immediately. Okay. Number two, okay, the common presenting features include headache, nausea, vomiting, photophobia, neck stiffness. Okay. But even if you have all these triad, you might be still missing a significant proportion of patient. Okay, if you're referring to my slide, only about 50% will have fever, photophobia, and also neck stiffness. So another 50% of them you will miss. And also different population present differently, like baby present differently, elderly present differently. So you need to have a very high index of suspicion. Okay, that's point number two. Take home message number three, treatment should be instituted immediately, and guidelines recommend that antibiotics should be given within an hour. All right. If at any point that you anticipate having delay to investigating the patient, for example, you need to transfer the patient to another center for CT scan and things like that, you should empirically treat the patient, meaning do not know whether or not it is meningitis or encephalitis, do not know what's the, is it bacteria or viruses, just empirically treat the patient. Okay. So finally, how clinicians make decision on what kind of pathogenic agent that is implicated is based on the clinical history and also physical examination. All right, the clinical presentation, like I've mentioned, CSF examination, okay, looking at what's the opening pressure, what is the protein, what is the glucose, what is the cell count, like, okay, based on the cultures from the CSF, viral PCR, and finally imaging. All right, so imaging can tell us where is the part of the brain that is affected and also how bad is the brain affected. All right, so I think these are the take home messages. Oh, final take home messages. Not all encephalitis is due to infectious agent. Okay, there is this entity known as autoimmune encephalitis. Okay, that I've introduced you to the movie in Netflix. So take time to watch it later in the afternoon. So there is a message from MZ, okay, again, messaging me privately. Hi, doc. Among viral meningitis, is it that enterovirus is the most prevalent when compared among HSV, VZV, EBV, and CBV? Okay, so referring to my slides just now, it depends on the age group that you're talking. So enteroviruses are common in children. In adults, it is usually herpes and also varicella zoster. Okay. Nofitra Azharuddin asked me, Doctor, does meningitis or encephalitis may affect other organ as well, like through hematogenous spread? Yes, of course they can, but usually the end organ impairment sometimes may be due to the fact that the patient is not drinking, very lethargic, very dehydrated. So, for example, if you are dealing with viral, for example, dengue encephalitis, very commonly, patients usually have liver impairment, okay, because we know dengue virus replicates in the liver. So to answer your question, yes, they can have other end organ involvement. Okay, so Ahmad Hilmi asked me, do we need to know about leptomeningitis and pachymeningitis? Leptomeningitis is spread due to the ventricle system, but I don't actually understand how pachymeningitis can be affected. Is it during direct spread, which is through fracture of the skull? I don't think, how do I say, it is very relevant clinically, because clinically, while looking at the patient, do you know why this is what membrane that is affected? No, you can't, right? So collectively, we say that, okay, this patient has meningitis. Okay. So what you need to know is is how do I say, it's not about direct spread or not. Okay, you in the at the bedside you need to know what are the risk factors for the patient to have this infection. For example, patients with base of skull fracture, you know that there's a break somewhere, viruses or bacteria can go in easily. Okay, patients who are receiving chemotherapy, you know that their immune system are very bad. You know they are very prone to all this infection. Okay, patients who are foreigner who are staying with in a very crowded places, they might get some how do I say infection like TB, meningitis, things like that. Right? Okay, any more questions? One last question. Kabilan Kumar. Kabilan, what is your question? What is your question? You stop at doctor. Okay, here, now your message. Too bad dah. Good day, doctor. Doctor, is it free of risk and side effects to introduce antibiotics without actual diagnosis? Very good question, Kabilan. I think you're a very careful person. You only do things when you know, how do I say, what exactly is the issue, is it? But this doesn't apply in medicine. Okay, anything that involves the brain is a medical emergency. Okay, missing a diagnosis of meningitis or encephalitis is devastating. Okay, so the longer you wait, okay, the more neuronal damage that you can have. So when it comes to the brain, if we have the slightest suspicion, we will initiate treatment while investigating. Okay, so kalau apa tu jari saja, okay, terkena kat jari jangkitan kuman, strep infection of the kulit, relax lah, buatlah dressing dulu. Okay, tengok, okay, kalau dah radang, kalau dah bengkak, oh barulah makan antibiotik, kan, betul tak? We can't do that for the brain. Hilang jari tak apa, tapi hilang otak tu, devastating, kan, betul tak? So Ong Yi Hang, okay, Ong Yi Hang said, Doctor, as you said just now, antibiotics may decrease number of cells in the CSF, but how can we do lumbar puncture after treating the patient with antibiotics? Okay, ideally, lumbar puncture is done before the administration of broad spectrum antibiotics, but that's not usually the ideal situation. Kan, patient come, you tell them nak ambil air tulang belakang, orang kata, tak nak, sakit, tak nak. Orang kata nanti lumpuh, orang kata mati pucuk, tak nak. So that causes delay. Okay, sometimes we have no choice but to start treatment first and then take our time to recounsel back and things like that. So sometimes, a lot of time, not sometimes, we don't get the CSF sample at all. So we rely on some other things to help guide us. For example, what are the patient's risk factor? The MRI, does it show certain characteristic that may point to certain organism to help us? Okay, but to answer your question, Ong Yihang, we don't withhold treatment without lumbar puncture. All right. Okay, so I think that's about it. Okay, I hope you guys enjoy the session. Okay, medicine is supposed to be very clinical. At this stage, perhaps when you study the books, you might not make sense of how do I say how is it going to be relevant next time. But when you come to the clinical years, you understand it more. Okay, so for your evening activity today, just tune in to Netflix, find the movie Girl on Fire, and then watch it. So it's a very good movie. I am sharing my email here. Okay. If you have any questions, feel free to email me. All right. Thank you very much. Bye bye.
Thank you so much, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you. Thank you. Buat apa? Gaji pun
Thank you,
sama.
Doctor.
Thank you. Buat apa? Gaji sama. Donate lah RM5. Ish. Thank you saja. Buat apa? Thank you tu boleh jadi nasi makan ke? Ish.
Thank you, Doctor.